First of all, I'd just like to say that I'm honored to be here tonight and to be able to speak to all of you. So today I'm going to talk to you about our work in modeling SCN8A epilepsy from patient-induced pluripotent stem cells. Oops, I think I went the wrong direction. There we go. Okay, so this is our model system. We are using patient biopsies to generate skin fibroblast cultures, and from these we are able to make induced pluripotent stem cells, and from these cells we're able to differentiate into patient-specific neurons. So these are tissues that we're not able to get from patients, so this is a really neat technology that's fairly new, and then from these cells we're able to look at the characteristics of these neurons. So this is from a review from Miriam Meisler. So this shows some of the mutations on the SCN8A gene, their location, and currently we've made iPS cells from 6 different patients with all different mutations, and the 3 that I'm showing here and that are in bold below are the ones that we've begun to characterize to date. But we've also made iPSCs from these additional mutations. And I'd just like to thank all the parents and patient donors that have contributed to this. A lot of you are here tonight. So these are what induced pluripotent stem cells look like. So this is just some immunostaining to confirm that these truly are pluripotent stem cells. And from these cells, like I said before, we're able to generate neuronal cultures. So the neurons that we've begun to study this disease with are deep brain cortical neurons, and they express some of these markers. And from these neurons, with the help of Lori Isom's lab and Dr. Luis Lopez Santiago, we've been able to look at sodium currents in these cells, since this is a sodium channel, and it's been known from some of the other work from Miriam and a few other researchers that there are differences in sodium currents. So what we've seen to date, in at least the cells that we've worked on, we don't see a difference in the peak sodium current in this small subset, but in 2 out of the 3 patients that we've looked at, we do see increases in this late persistent sodium current. And that's, we believe, due to impaired inactivation of the channel. And so this is quantification of all the data that we have so far. So control cells have a small amount of persistent sodium current, but we do see a rather marked increase in patient 1 and patient 2. And interestingly, some very new data, patient 6 does not have this increase in persistent sodium current. And this makes sense based on some of the other labs that have been modeling these different pathogenic mutations. There's not just one mechanism in this gene leading to epileptic encephalopathy. So this has a lot of implications for drugs potentially. And another thing that comes out of this with persistent sodium current is you get an increase in input resistance. And I'm not an electrophysiologist, so I can leave that for them to explain. So we wanted to see, do we see an increase in the amount of neuronal activity in patient cells compared to controls? And so to do that, we're using a fairly new technology. It's a multi-electrode array plate where we can grow these neurons in individual wells. And in the bottom of each of these wells, there's implanted electrodes. And we can simultaneously record from all of these electrodes and get neuronal activity. So each of these lines here, well, in this direction, each one of these is from an individual electrode. And then this is time on the x-axis, so each of these lines is an individual action potential. So we've had a lot of difficulty in figuring out the best way to make these neurons because there's a lot of variability in these differentiations, but we've used a new technique that seems to be very consistent, and I won't go into the details of that right now. But what we see in comparing patient 1 to 2 different controls, we see a very drastic increase in the amount of activity. So this is the number of the spike frequency, and this is recording over a couple of weeks in culture. And so we see a huge increase in the amount of spikes in these patient cells. In addition to just the overall increase in activity, we see differences in bursting. So bursts of activity are thought to be important for hyperexcitability, which could lead to potentially to seizures. And so what we see in both patient 1 and patient 2, which all that data is averaged here, we see a big increase in the number of spikes in an individual burst of activity. And this is driven mostly by a reduction in the time distance between these individual spikes, not an overall increase in the length of the burst. And this is just to exemplify what it looks like. This is data over about a second showing a network burst from a control individual and an SCN8A patient culture. And you can see that there's a lot more bursts overall, or spikes overall, and a shorter time period in between. And Yuan, another collaborator of ours from Michigan State University, he's been able to see this at the single cell level as well. So he recorded from controls and also from patient 1. And you can see the same difference. We see this increase in the number of spikes per burst and a shortening of the interspike interval. And then also we see an increase in the number of spontaneously active neurons in this culture. So we wanted to look at not only the activity of these cells, but also the morphology. So as most of you know, NAV1.6 is located primarily in the axon initial segment. That's the place where it has the largest expression. So the axon initial segment is located here on the axon, very close to the cell body, and this is very important for initiating action potential firing. And we used an antibody for ankyrin G. It's a label for axon initial segments, and I just showed this at a conference on a poster just to show that we were getting very mature neurons because the majority of these cells had very defined axon initial segments. Interestingly enough, someone came up and said, you know, it looks like there's a big difference in the length of these axon initial segments. So we went through and quantified this, and it was a very obvious difference between so far patient 1 and patient 2 compared to control. And this is 2 different ways that we made the neurons. We did this in both of these techniques just to make sure it wasn't an artifact of our differentiations. So we kind of took a step back and thought, well, what's causing this? And if you look in the literature, when cells are hyperexcitable due to changes in the media that they're grown in, it can lead to this shortening. So this could be a compensatory mechanism in the patient cells to try to decrease the amount of activity. So currently our understanding of how this disease works, at least in our limited study so far, is that SCN8A missense mutations can lead, in some patients, but not all, to increases in persistent sodium current, and that this leads to an increase in repetitive firing. And an aside that we want to explore more is this can lead to responsive axon initial segment shortening. And this might also be an interesting thing to look at when we try different therapies to see if that restores the normal length. So we're making these cultures not just to characterize the mechanism, but also look at making a platform to test different pharmaceutical compounds. So today, as many of you know, for most patients, the best current therapy is phenytoin. But and this has also been shown in some small studies that there seems to be increased specificity for the mutant SCN8A channel. But we wanted to compare to another drug which hasn't been used for epilepsy, but inhibits voltage-gated sodium channels, and more specifically it's thought to inhibit persistent sodium current with some specificity. And that's called Riluzole, which actually comes from the ALS, treating ALS. So this is very preliminary so far, but we've been able to test what the effects of this drug and phenytoin are on the activity in the patient cells. So on the right, this is just to remind you the phenotypes that we saw. But you'll see that there's a reduction with both of these drugs in the number of spikes per burst, and this is due to a shortening of the burst duration. And we haven't done full dose curves to look over a broad range, but just a quick literature search showed that really the maximum dosage that I can find that you would get in a patient without really severe side effects would be about 15 micromolar phenytoin, where Riluzole, it looks like you could get anywhere up to about 3 or 4 micromolar. That might not be perfectly exact, but that seems pretty close from the literature. So these are those 2 wells that are bursting, control and patient, and this is what happens when you treat with Riluzole. And you can see this shortening in both control and patient in the length of the burst. So we think that this could be a potential therapy. It's very early to say much more about it. But one nice thing is this is already an FDA-approved drug. So future directions we'd like to fully characterize in these patients and our additional iPSC lines, activation and inactivation kinetics. Part of that is to look beyond just persistent sodium current at what the mechanism between and the differences between these patients are in their sodium currents. And we also want to do the full dose response curves for these 2 compounds as well as some other potential therapies. And we want to test to see if either of them has any specificity for the persistent sodium current or rescues the axon initial segment length. And this is much more long-term, but we want to potentially look also in GABAergic inhibitory neurons just as a comparison. And then I know that there are some NAD 1.6 specific drugs out there, like Xenon has talked about, and we could potentially test those as well. So I'm not the only person working on this. We have a good collaboration between my PI's lab, Jack Parent, Lori's lab, as well as Yukun Yuan. I put him under her lab, but he has his own lab at Michigan State. And I also like to highlight my fellowship funding from Wishes for Elliott. And with that, I'll take any questions. Okay, sorry, no questions.